Today, I'm talking with one of our neurosurgery residents, Dr. Michael Catalino. He spent the last year at Brigham and Women's Hospital in Boston as a clinical fellow under Dr. Edward Laws in pituitary surgery and neuroendoscopy. And while he was there, he was redeployed to cover a COVID ICU unit during the pandemic. He's now safely back in Chapel Hill with his family, and he has agreed to share a little bit about his experience and what it was like working in a COVID ICU. So Dr. Catalino, can you tell us a little bit more information about your neurosurgery training while you were in Boston?
Yeah, so the last year I spent with Dr. Edward Laws doing specific subspecialty training in pituitary surgery and neuroendoscopy, also getting extensive training in neuroendocrinology, in the management of functional pituitary tumor patients. These include acromegaly, Cushing's disease, and prolactinomas. And so I collaborated with a lot of folks from Dana-Farber and the pathologists, Umberto De Girolami and David Meredith, as well as Ursula Kaiser, Lee Min, and Anna Paula Abrametzer from endocrinology, and Dr. Eduardo Corrales from ENT. We had a great team working with a nurse practitioner and a wonderful administrative assistant as a complete pituitary unit.
When you were first redeployed to cover a COVID ICU unit, what was your initial reaction?
We knew when I was in Boston, after seeing what happened in New York, there was concern that a similar situation could occur in Boston, where the hospitals were overwhelmed and the ICUs overwhelmed with patients, making the ability to care for critically ill COVID patients nearly impossible. Thus, multiple units opened up across different hospital systems they were called COVID surge units. And as the elective surgery volume decreased, including the pituitary surgery that we were performing, we were all put into a call pool or a pool for possible redeployment. The situation occurred that under Partners in Health, now Mass General Brigham, called Faulkner Hospital, had opened a surge unit for COVID patients and needed additional assistance because of various staffing issues, whether it was staff members becoming ill or just staffing the additional units. They needed additional coverage, and thus they reached out to multiple call pools for redeployment, and ultimately it came to us, and we were tasked with providing at least 3 upper level residents or fellows to cover night call at Faulkner Hospital. And the opportunity really was discussed with us, and we were told that we can volunteer, or they will randomly select somebody, 3 upper level residents and fellows. And once we heard that, there were a number of us who volunteered for the position. The surge unit wasn't open for very long because the curve was flattened, so to speak, in Boston, which was great news, because everyone kept really strict precautions, both in the community and in the hospitals, to prevent community spread of the disease. And so even though we were only there for a short period of time, it was definitely a meaningful experience.
You have to quarantine yourself from your family while you were working in the COVID ICU?
So we initially, I was actually going to try to quarantine myself at a different location, but it was difficult. There weren't a lot of hotel rooms available for a long-term stay, and we couldn't afford that at the time. But I was fortunate enough to have my employer, Partners in Health, now Mass General Brigham, provide a hotel room before and after the day before and the day up until the day after my last shift. So I never had to go directly home to my family. I could sleep and stay in a hotel room until I was done with the night shift stretch, and then and then I could go to the hotel and, clean up and then go home. And I had a regiment that I would follow that was very strict, to prevent myself from bringing home dirty or contaminated clothes after a night shift. So I had basically a routine that I got into to prevent that from occurring. And so as long as I could prevent myself from getting sick, I knew I would prevent contaminating my family. And so then I just had to watch out for, making sure that I didn't develop any symptoms. But I didn't fully quarantine from my family, basically just because it was not feasible for me.
Thank you. What did the average day in the COVID ICU look like for you?
We started off and we would round on every patient. Most of them had COVID, and there were a number of patients who, and actually nearly all of them were on ventilators. And we would go round with, I would round with one of the other fellows, and we would round on each patient and discuss the patient's plan for that evening. Most of it was what was provided at our sign out from the day team. And then after making rounds and assuring the stability of all the patients, we would essentially address small issues that would come up during the evening. We had a couple, actually each night I was there was at least one patient who was deteriorating either from a respiratory standpoint or a cardiovascular standpoint, either in shock, cytokine storm, sepsis, just severe hypoxia, and we had to deal with that. So usually the time was spent mostly rounding and then caring for one or two very, very ill patients that needed ongoing management. And then at the end of the evening or the early morning, rounding again, and then signing out to the day team, for the events overnight.
Were you ever concerned about the lack of beds or staff in the COVID ICU unit while you were there?
There was never a lack of hospital beds. They actually built a number of ancillary facilities that weren't used. A lot of that is because we were able to flatten the curve as community members.
Despite the rising number of cases, there are still many Americans who refuse to wear masks in public and downplay the severity of the coronavirus pandemic. What would you say to those people?
What we have to be mindful of is that the risk to our community and our country is high right now, and that the lack of awareness and the disregard for the public health responsibility that we have is problematic. We have to be cognizant of wearing the mask. We have to also be aware that our daily practices of hand washing and general awareness of close contact with other people, whether it's through social distancing, or just awareness of who it is that who we are near to. If we know that we're going in and out of the hospital, like I am, for surgical cases or for other types of patient care, we may be exposed to more people, and have to be mindful of that and not put others at risk, especially now given that the rates of infection are increasing in our country and in our state.